This morning we're going to talk about an issue that I don't think we've covered before on this program, and I have with me a very interesting and accomplished guest to talk to about it, and it arose from something I read that I'll come to. My guest is Dr. Janet Giddy, who is a UCT medical graduate and a family physician and public health consultant, and has had considerable experience in rural medicine, primary health care, HIV, TB care in particular, and maternal and child health. And she's interested and involved in the issue of transgenderism and the medical implications of this. And this is really what we're going to deal with today. Firstly, Janet, welcome to the show.
Thank you for having me. It's an honor to be here and to have a chance to talk about this issue.
I've been aware of the issue in the context of private schooling, but there was an article published by News 24, which I thought was rather poorly written. And essentially, it dealt with accusations by certain transgender activists and individuals and groups against a group of what we call professionals who they accuse of a number of things. And you are one of the members of that group of medical professionals. And the group is First Do No Harm South Africa. Janet, before I look at some of the things of which you are accused as a group, could you tell us what is First Do No Harm South Africa?
Well, it's actually First Do No Harm Southern Africa. So we have to have a broader reach, and we do have supporters in surrounding countries. So First Do No Harm Southern Africa, we'll just call it FDNHSA, which is how we refer to it, is a voluntary association of professionals. And it was started, the founder members were all doctors, but we're not limited to only doctors. So it's a little bit broader than that. And we have quite a diverse membership, certainly predominantly doctors. And it is, what I need to make really clear, not a religious group. We've been accused of a number of things, and one of them is of being right-wing Christian fundamentalist transphobes. But we are not a religious grouping, so everybody's faith position is their own personal thing. And in the group, I can say we do have atheists, people who say proudly, I'm an atheist. We have people who are Jewish. And we have people who would call themselves in the LGB category. And we have people in the group who are parents of young adults who have embarked on this very difficult, I don't know what to call it. They are in this gender affirming kind of pathway. Let me put it that way. Terminology is quite a complex thing in this issue. And so I always have to think carefully when I'm using the words, because words have such impact and such meaning. But yes, so we are a very diverse group of professionals, but with quite a heavy preponderance of doctors.
Mm-hmm. And what is the focus of the group? And why did you come to form the group? What were the circumstances that led a group of professionals to form a grouping under your banner?
Well, I think that it was that a number of us were quite separately engaging with this issue in very different ways. And we were sort of all doing our own thing in our own kind of space or corner. So, for example, I'd been interested in the issue for at least 5 years. There were other people in the group who'd been thinking and writing about this for more than 5 years. But it followed, I think the actual formation of the group followed a talk given by a Finnish psychiatrist called Rita Kaltiali. It was a webinar, actually, and she talked about what had happened in Finland in terms of, as a country, the process they'd been through in terms of how to deal with the issue of, let's call it gender questioning or gender distressed or gender dysphoric children, adolescents, and young people. And at this webinar, she gave incredibly fascinating data about the changes that had happened in Finland and what the country had done. And she was the chief psychiatrist. and ran the biggest gender clinic in the country. And she was saying, we made terrible, terrible mistakes, and we've had to completely revise what we're doing. And actually, the people on that group started talking to each other. And that was, I think, in about June, mid-2023. And we just started having conversations, and at some point we realized that it would be very beneficial not to be all in an individual way trying to do something, but to actually, as a group, support each other. So we spent the latter half of 2023 kind of working on our let's call it organizational issues, and trying to work out what it is that we stood for, or what we wanted to do, what our focus would be. So I'll actually just read here the mission statement. So it says, we're a voluntary association of South African professionals advocating for evidence-based care of children and youth with gender dysphoria, gender distress, or gender incongruence. And we say we will support professionals, parents, and members of the general public who pursue or promote practices that are evidence-based. We will challenge practices where the evidence base is weak and risk of harm is high, or where significant bias is present. So, yeah, I mean, that in essence is who we are.
Just to look at the name, certainly from a layman's point of view, my understanding of it is really that it's part of the fundamental obligation of a medical professional to the public to avoid doing any harm, and that if anything has to be dramatically done, and I assume in a large measure it will be, for example, surgery, not the first port of call in this process, if it's necessary at all. Am I sort of on the right track?
Yes, Sarah. In medicine, we have 4 foundational ethical principles. You know, people often, when they think of doctors and ethics, they think of the Hippocratic Oath, which is quite a general kind of document with lots of aspects. And if you ask most doctors what was in the Hippocratic Oath, it will be difficult for them to answer easily. But what most doctors should know is the 4 ethical principles. It's sort of like our foundation or the pillars of the profession. And these are, the first one is beneficence, which means to do good.
Mm-hmm.
The second one is non-maleficence, which is to not do harm. Basically, do no harm. The third one is autonomy, which means respecting that people, you know, have free will and autonomy, and, you know, that's where the whole thing of consenting people and so on comes in. And the final one is called justice, or some people say distributive justice, to make sure it's something around equality and equity, and making sure there's fairness in the health system. So the name of our organization, First Do No Harm, is kind of based on the second principle. And I shouldn't really say they're 1, 2, 3, and 4. They're not in a hierarchy.
Yeah.
I've just given them like that. So non-maleficence, or do no harm, is there's a Latin word, and I've sometimes seen it tattooed on people, prima non nocere, which is the Latin for do no harm.
Mm-hmm. The issue around which the controversy has focused is the fact that your organization takes a different approach, and particularly to the issue of gender dysphoria in children, adolescents, and vulnerable people. I don't understand it as being a question of prescribing a course of action that adults who have reached adulthood and are fully autonomous beings. My understanding is that one of your main concerns is that mostly people who don't yet have the capacity to make completely autonomous decisions around an issue that will have lifelong consequences for them. And I think for most people out there, their concern is that there are 2 elements to this. The one is that you take a child at the child's word, irrespective of what may have influenced that word. And linked to that is the fact that parents in loco, such as teachers, are there because children do not have the capacity to make decisions that should be made rather in adulthood. and B, a tendency by transgender activist groups to promote the provision of puberty blockers and even the removal of genitalia, breast removal, penis removal, etc., in order to realize a child's transgender, sense of being transgender. It's a terrifying thought. Having children, seeing them go through puberty, seeing them go through the craziness that is teenagehood, the idea of making irreversible, life-changing decisions is both terrifying and, to some extent, I guess, rather repulsive if it can be avoided.
You've raised quite a lot of really interesting issues, but maybe let me take as a starting point what I was talking about with those 4 principles. Now, how do we know what is beneficial or good or what is harmful? That is dependent on the evidence. And so another huge foundation in modern medical education is the idea of things being evidence-based. How do we know what we know? How do we know what is true, what is not true, what is good, what is bad? We need to look at the research and the studies. And so I think the big challenge with this area is there's a lot we don't know, but there are things that we do know. And I think in terms of, you distinguished between children and adults. So if we leave aside adults for the moment, because that's a whole complex contested issue, and the question of whether gender affirming medical interventions in adults is good or not good, I'm not going to talk about that now, but let's just talk about what are called gender affirming interventions in children and adolescents and young people. And I would actually extend it up to the age of 25. You talked about the confusion of adolescence, and people think that adolescence ends at 18 or 20 and then you're an adult. But actually what the neuroscience tells us is that adolescence extends right up until the age of 25, that the frontal lobes are not fully mature, and the parts of the brain that are involved with, rationality, reasoning, and a lot of executive function and adult behavior are not fully mature at 20 or 21. So we see that there's a very vulnerable group of people between 18 and 25. And it's interesting, the Cass review that in England, the UK tried to examine the evidence and really look at this question of benefit versus harm. They only went up to the age of 18, but they wanted to find out what happened to the 18 to 25-year-olds. But those young people then transitioned into adult gender clinics. That was considered to be an adult, and those clinics refused to allow the Cass review investigators and the people who are trying to understand the evidence access to the records of those adult clinics, which of course is very interesting. When you are not allowed access, that tells you a whole lot. But anyway, I just want to come back to the point that the vulnerable group we're talking about would extend into what I would call young adults. And in terms of the evidence, we don't have good evidence of benefit, but we actually have increasing evidence of harm. And we know that from multiple systematic reviews that are being published now. And a systematic review, in terms of medical evidence, there's a kind of hierarchy of what is the best evidence. And right at the bottom is what's called expert opinion. That is the lowest evidence. The professor says, I think, et cetera, et cetera. And even though he's considered as an expert, sometimes it's just what he or she thinks. It's a bit of thumbsuck, you could say. And then you go on to case reports and et cetera, et cetera. But right at the top of there's a kind of pyramid of evidence, of hierarchy. At the top is something called a systematic review, which looks at many, many different studies, meta-analyses, randomized control trials, et cetera, and synthesizes it all and says, what does it say? So there are an increasing number of systematic reviews being done on the subject and published in different countries. And actually the Cass review, which was this kind of landmark British report that came out in April last year, it was headed by a very well-known British and respected British pediatrician called Hilary Cass. And there were 8 systematic reviews that were done as part of the final Cass review. The US Department of Health and Human Sciences, the HHS, has recently, actually on the 1st of May, released a similar document, similar to the Cass review, on pediatric gender medicine, that's what they've called it, and they too have done all these systematic reviews, and all of these reviews found very, very little benefit of gender affirming care, or what I might call the medicalization of gender dysphoria. And as you said, Sarah, that involves the use of puberty blockers around the time of puberty, and the effect of puberty blockers on a young person are very, very severe, and they include effects on the brain, cognitive development, effects on the bones, effects on their future fertility and ability to have sexual, function. And then puberty blockers, the vast majority of children who started on puberty blockers then transition to cross-sex hormones, and that adds to in a sense, the irreversible damage that you refer to. And then in many cases, children are operated on, some of them below the age of 18 in other countries. I don't think that's happened in South Africa, but the use of puberty blockers and cross-sex hormones in children is definitely happening in South Africa. I mean, it's interesting. I was just texting a friend who lives nearby, who's a pediatrician, and she was telling me last night about a child who is at school with her child, and she calls the child a boy, but she says, I think this is a biological girl, and he is starting to grow sideburns. I'm sure he's on puberty blockers and cross-sex hormones, and he is like 9 or 10 years old. So we know that there are children, and we know that there's a clinic in Cape Town that falls under Red Cross Hospital that has been providing, what people call euphemistically gender affirming care, what I would call the medicalization of children. And the evidence base for the benefits, as in this will help children be less confused about their gender or less unhappy with their gender. The evidence for that is extremely poor, is what multiple systematic reviews are showing. And the evidence of the harm to the body of giving these very powerful drugs and medications is increasing. And we also know that there's an increasing number of detransitioners. These are young people who've been given this gender affirming care, and including, some detransitioners have had bilateral mastectomies, breast removals at the age of 14 or 15, and they're coming out in their late teens or early 20s. You will find multiple examples, or it sounds terrible, but yeah, people who are telling their stories and saying, please don't let this happen to other young people. So yeah, the benefits and the harm are based on evidence. And what's really interesting is what started this whole kind of, I don't know what to call it, this whole process. I mean, other words come to mind, but they're less complimentary. But this whole process of providing gender affirming care to children started with 2 studies that were published in Holland, and they're often referred to as the Dutch studies or the Dutch protocol, by the main author is somebody called De Vries. And they purported to show that this gender affirming care was beneficial, but there have been very serious criticisms of the Dutch studies and shown that they were not good research, they were not ethical research for multiple reasons. And you can read about these easily online, but that just started this unbelievable thing all over the world of assuming that this was good research, and it was. And what actually happens in medical research in terms of the evidence is, if somebody has a finding and it's an isolated finding in one clinic, other sites and other settings need to try the same under research conditions and say, yes, we agree, we're doing it, because we know that science is a whole process of, you have a hypothesis, you test it, you put something out, other people test it, until you come to what is the best evidence. But what happened was that these very flawed studies were taken as being solid evidence, which they've now been shown not to be. But this phenomenon just swept through many, many countries.
I'd like to go on to some of the accusation laid at you, because They penned a letter to a medical journal, South African Family Practice, suggesting that gender-affirming healthcare for transgender and gender-diverse people should not be practiced. This was a response to an article that had previously been published about what family physicians need to know. And essentially your article, they say, said the heading is gender-affirming healthcare is not what the family physician needs to know. Essentially what you're doing is unorthodox, and that there have been inaccuracies and inappropriately discriminatory references in what you've written, and that this has led to numerous complaints being lodged against your organisation with the South African Human Rights Commission. They've demanded a retraction of a letter. This is not an article, an evidence-based article, it's a letter. But it's demanded retraction because it's framing identities as mental health issues by calling gender diversity, gender confusion, or gender distress mental health issues. They accuse you of using words like etiology and epidemiology, which are only used when talking about a disease and inappropriate when referring to gender identity. They accuse the letter of building arguments using ideology rather than fact and evidence-based practices, and it tries to frame the lived experience of transgender people being open for debate. Now, it's clear, it's come out of the woke period, that the way to deal with an opposing view and suggested practice of any kind be shut down, be essentially put into a position where it can no longer be heard and discussed. Your comment on what it is they're accusing you of?
Yeah, I think, Sarah, you've also again raised many, many issues to respond to, and very interesting issues. I think basically there's what they're obviously accusing us of, that you can read an article, but then there's basically underneath that, what they're accusing us of is of having a counter narrative, like this idea that there's something called being transgender. You mentioned that a bit earlier, and actually I just want to start with that point in terms of terminology. What does the word transgender actually mean? It is very difficult to find a proper definition. So we are in the medical sphere, and in medicine you need to have a clear diagnosis or a definition. If this is an identity issue, if, for example, this was something like being same-sex attracted, and we know that in the past, and there's a lot of linking of LGB issues with T issues, and we see this, I don't know if you call it an acronym or what, but this collection of causes sort of put together, LGBTQIA+, and the plus is to allow for an infinite number of others. And these are all grouped together as if they're one thing, but they are not one thing. And something I just want to tease out quickly is the idea in the past, if you were LGB, i.e. lesbian, gay, or bisexual, that was seen in a certain way in society, and people felt as if LGB people didn't have the same set of rights, etc., etc. And of course, there's truth in that. And there was a huge struggle to say that people who are lesbian, gay, or bisexual are absolutely entitled to that sexual orientation, and they shouldn't be discriminated against, and that's fine. But what's happened is the T's been added to that as if it's the same issue, but it isn't the same issue at all. And the idea that being what people call transgender, and I say that because I'm not sure exactly what that means in a medical sense, and I do tend to view things in a medical sense, is if you were LGB, the medical profession did not have a role to play in your identity. There might be in the rest of society, in schools, in churches, in wherever else in society, there may be a response to being LGB. But with the T, what's happened now is people are coming and saying, this is not a pathology, this is an identity. But for this identity, we demand that you give us puberty blockers, cross-sex hormones, and provide surgery. And don't call it a disease and don't pathologize it, but give us the drugs, give us the surgery. And so in a way, the medical profession has to come in and say, so what are you asking for? You know, actually the normal process of medical care is somebody comes to a doctor or healthcare provider and says, well, I've got this problem. You take a history, you examine the person, you assess everything, And then you look at the evidence and you say, is this a medical condition for which there's good evidence to do this or that? So what the trans activists are saying is, this is not a medical condition. Don't ask questions. If you ask questions, you're gatekeeping, and you're not allowed to gatekeep. You must just give us what we want. And in a sense, what they are calling on in terms of the 4 principles is autonomy. It's my right. And they're framing this as a human right rather than a medical demand to treat something that is called an identity. So you see how for doctors it can become very, very confusing of what's going on. But for a lot of doctors, they don't know what to say. So going back to your question about the article, the letter we wrote to the South African Family Practice, yeah, it was a response to an article, not a letter, but an article written about a year before by a group of doctors who are gender-affirming activist doctors, predominantly, I would say, in which they were saying that gender-affirming care must be provided freely in the health system in South Africa, and it must be provided at all levels, and family practitioners should lead the, charge in a way in terms of this demand, and it must be provided right down to primary care level, i.e. in clinics and potentially by primary healthcare nurses. So that article is called Gender Affirming Care, What the Family Physician Needs to Know. And they take, in a sense, the model of how HIV care happened in South Africa, which is it started off as specialist care in hospitals, and then eventually it was decentralized right down to primary care with protocols written for nurses. So nurses could provide HIV care because we had such a massive HIV problem. So that was the appropriate thing. We had to find a way to get the care to all the people. But they're doing the same with this issue. They're saying it must be widely available throughout the system at primary care level, decentralized, and we must just write protocols. And in the article, they made it sound really, really easy. Well, this is the easy thing about estrogen, progesterone. We should be like basically handing it out. Whereas these are very powerful drugs, even in adults. They have very, very powerful effects on people, and there are serious, let me call them adverse events or side effects. We have a member of our organization who works in an endocrine clinic. She has been forced to provide gender-affirming care to adults and cross-sex hormones, and she knows, and she has done an audit and collected a lot of information about the side effects. So the idea that gender-affirming care should be decentralized to primary care level is just unbelievable. Our health system is currently facing enormous constraints. We're really struggling. There's austerity measures, budget cuts, and now they want to add a new service for something that's not called an illness or a condition, but an identity. And they're demanding it's provided throughout the system, and the evidence base is not good. So our letter was saying, you know what, this is a problem. This is what we're talking about. So everything that I've just briefly explained here is in the letter, and people can access it. South African Family Practice Journal, and type my name and Janet Giddy, you will be able to see that letter and see what our arguments are. But I think that what happens with the gender activists is if you challenge them, they don't engage in a reasonable discussion. Okay, let's think about the pros and cons. They attack you and they accuse you of being guided by ideology, when actually the opposite is true. We're approaching this from a medical point of view, saying like, okay, you want medical treatment. What's the medical problem? How do we understand it? So what does the evidence say? And they're saying, don't ask questions, don't gatekeep is the accusation. Just give us the drugs, like basically behave like a medical ATM. But yes, you must also look after us. So, a woman who's taking testosterone, it's injections for the rest of your life. It's medical care for the rest of your life. You become a permanent, perpetual, chronic patient. You have to have blood tests because you might develop a condition called polycythemia, where your blood becomes too thick because of the testosterone. There are many, many complications of these drugs. And they're just saying, give us the drugs. Oh, yes, and please look after us. And we must have it all for free and don't ask questions. So, and when we ask questions, you get accused of being guided by ideology, which is kind of ironic.
What's really terrifying about that, and seems to have been very much part of the blowback against the sort of radical transgender activism, is that it's the very lack of information and conveying an understanding of what those interventions can do medical science is wonderful in the sense that we're all living longer as a result of extraordinary developments, pharmaceuticals, surgical, etc. But what's very concerning is that children with gender dysphoria will likely be lesbian or gay once they reach adulthood. It's like something out of a movie. You are performing experiments on people, but with lifelong involvement and lifelong consequences, without there being the evidence that in the long run it will resolve most of the problems that are picked up in childhood or in adolescence to do with identity, without being given the chance to work through it in other ways before you resort to something as dramatic and as invasive as medication and surgery. What, in fact, the activists accuse you and others of presenting growing misinformation and disinformation, that you fuel the stigma. If there's a stigma, it's the stigma that needs to be dealt with. You're not going to deal with the stigma by trying to physiologically change something dramatically.
I didn't actually answer your question about the attacks against first do no harm. So let me say that quickly first, and then I will respond to this. So you mentioned alleged complaints laid before the Human Science, the
Human Rights Council.
So we saw that in that article, but we have never received any notice of that from the Human Rights Council. So I just want to say we don't know if that has been done. Clearly, the Human Rights Council has either dismissed them or is still processing them. We would have expected that they would get hold of us and tell us a complaint had been laid and ask us to respond. However, what I can say is that 3 members of our group have had complaints laid against us with the Health Professionals Council of South Africa, which is the body that regulates health professionals. So 3 of the doctors in the organization have had complaints laid against them. And we were informed of this. We were given the right to respond. We've all responded, and we're waiting for the outcome of the deliberations. So the point is, there has been an attempt to professionally sort of make it difficult for us. But I think that the purpose of doing that is not against the 3 of us, but it's actually against people speaking out in general, because people know that this has happened. And so it's a way to threaten other people. If you speak out, well, you can have a complaint laid against you with the Human Rights Commission, which may or may not be true, but it certainly is true with the Health Professionals Council. And we can also write articles about you. I've also received very, very hostile, aggressive emails after that article was written from, there was one that was from an academic at UWC. And so you will get a lot of negative pushback, and it's a way to silence the discussion again. But now to come to the question you asked about, what could be seen as experiments on children with lifelong consequences, and that if you talk out about this, you're accused of misinformation and disinformation and creating stigma. So I think at the heart of this issue lies the thing of consent. If anyone's going to have a medical intervention or treatment, at whatever age, someone has to give consent. And that's also part of the whole, the principles of good medical practice. You tell people everything you know about this thing and then say, well, this might be helpful or not. But even that approach is being challenged in a way through this whole thing, because children can't really consent to interventions. And in fact, what happens is parents have to consent. So you're actually putting a burden on the parents. And it's one thing to say, sign consent, your child's got a broken leg and has to have surgery, as opposed to, well, we could give them these, very powerful drugs to change a boy into a girl. And parents are not properly told the evidence, whether it's going to be beneficial if the treatment, so to speak, is being given for gender dysphoria. What is the evidence that will improve gender dysphoria? the evidence is very poor. Are they told about the lifelong consequences and the harms? You know, can a 12-year-old understand what it means to be told, well, you may not have sexual function, you may never be able to have an orgasm, you know, if you may never be able to have a baby or a child, they'll say, oh, no, I'm not interested in that, I don't care. They don't really understand. So this isn't about misinformation and disinformation. It's actually misinformation and disinformation to assume that a child or their parents should consent to something that even the medical profession doesn't fully understand. So, and then to use the idea that you know, that this, by telling people the truth, that we don't know if this is an experiment or not. We don't know how many people will regret it. We don't know how many people may want to transition. We don't know. We know we probably can't reverse if you've removed a young man's penis and made a false vagina, and there's all sorts of problems with their urinary tract thereafter. We don't know we can fix that. We probably can't. And so what is misinformation, disinformation? Those are words that are flung around very easily these days, and they like slurs. And so, yeah, so I think also the word stigma is a very interesting one. You know, that is also a card that's played to make people feel bad. And actually, I think the difficulty with having a rational discourse about this, apart from all the intimidation and bullying, is the fact that a lot of emotive, manipulative tactics are used. You know, I've recently published an article about what's happening at UCT, which we can talk about another time. But what's really interesting is when I engaged with the senior management at UCT on this issue about providing information to the health science faculty, to medical students, etc., about this, what was really interesting is a senior person said, yes, but whatever we do, we must not offend the sensitivities of our LGBTQIA plus community. So they were less concerned with the truth, the information or disinformation, than about people's feelings. So this idea of sort of being more concerned about the emotional feeling subjectivity, appealing to that side of people rather than what is the evidence, what's good practice, what are the long-term consequences. So the whole debate has got skewed around emotionality, I think, and not rationality.
No, I think it's generally agreed that part of the process in a lot of woke activist movements is to invert the meaning of language and to use language emotively and to say almost the opposite of what you mean. And what I'm particularly struck by what you said is one of the activists talked about transgender and gender diverse persons should be able to access primary healthcare facilities. The reality is, if you take that as I read it, it means they're being barred from getting healthcare for stigma reasons or whatever. But that's not. Everyone is entitled and has a right to healthcare, and that includes people who consider themselves or transgender or gender diverse. What they really are meaning, as you point out, and that's quite astonishing, is not that they are being prevented from receiving healthcare, because that immediately evokes an emotional reaction about people being treated unfairly because they've got a certain condition or a certain identity. But what they mean is make available the medication, the hormones, the access to surgery, etc. It's a fundamentally dishonest and deliberately dishonest approach, and yet it's being brought into as kind of don't offend people's emotions, even though what they're saying has to be challenged and must be challenged. That's the other thing is the assumption that universities or anyone or in any other institution needs to be sensitive to the LGBTQIA community. It is not a homogenous community. In fact, there's a lot of debate and discussion, and perhaps I can get your view on this, that the transgender community is in fact in opposition to the LGB community, because the very idea of transgendering a man to a woman suggests that part of the philosophy or the ideology is that you will not have gay men gay men they'll be women. You will not have transgender men, because lesbians will become men and not lesbians. And that in itself is a complete denial of other people's existence as...
Sarah, again, two very interesting, slightly different issues you raise. So I'll try and deal with them separately. The first one is, and when you talked about inverting the meaning of language, yeah, I think it's very interesting. Your point that I would absolutely support is that LGBT people have access to all normal health care. So if you're diabetic, you can get diabetic treatment. If you've got HIV or TB or any other condition, primary general health care, there are no reasons why that community cannot access that care. So when they say that they are not able to access healthcare, what they mean is the gender affirming care on demand that they want. And what they are doing, and again, it is unfortunately a very common and manipulative technique, is that they are positioning themselves as a marginalized, discriminated against group. In a way, it's claiming that sort of victim status, like, we experience unique discrimination. We have our very existence threatened because we are not getting proper healthcare, et cetera, et cetera. And so the whole discussion, moves from what is actually happening to an emotional appeal. So, yeah, that is problematic. But then your next point about the fact that the LGBTQI community is not homogenous, that is absolutely true, and that they don't necessarily all want to be in the same boat together. And so, for example, as I mentioned, there's a member of First Do No Harm SA who is a doctor who is lesbian, and she's a South African and she trained here, but she's currently working in the UK. And she rails against this issue of being put into this kind of forced, I don't know what to call it, forced marriage or grouping with the trans activists. And she would be one of those people who would say exactly this, what you said, Sarah. I mean, people even have a phrase for it. They call it trancing away the gay. And so if you have a 13-year-old young woman who is same-sex attracted, nowadays, she said, it's very unpopular to come out as being lesbian. It's much more cool, or the influences around you, your friends, social media, et cetera, is to say, oh, well, if you're attracted to women, you probably trans. And yeah, so that's the trancing away of the gay. And in the UK, the LGBT community have organized themselves to actually push back. And so they have organizations like the LGB Alliance. And in the US, I think there's a similar one called the LGB Courage Coalition or something. So they are saying, not in my name. We don't actually, what you're saying and doing is actually harmful to the identity and who we are as people. It is denying our existence. So yeah, there's a lot of uneasiness with this thing. And then putting the I in there, the intersex, also confuses things hugely. Right. And it's interesting, I spoke to a very senior pediatrician at Red Cross initially about this, about 18 months ago, about the clinic at Red Cross. And he immediately started talking about, he thought what I was talking about was what in that thing is called I for intersex, but actually in the medical world, we call it disorders of sexual development. And this is a very, very specific set of conditions that somehow has also been lumped in here. Now, people with DSDs or who are intersex, if you want to use that word, I don't personally particularly like it, but they have very specific health needs and situations. And so to lump them all together as if they're homogenous doesn't do anyone any favors, except the trans lobby, who think there's sort of power in numbers and that we're all on the same mission to change the world.
It's got all the hallmarks of a form of student activism, with all the limitations that comes with, and that's basically knowledge and information, and the techniques to put it forward are aggressive and violent and accusatory. Janet, thank you very much for your time. Where can, if people want to get hold of you or the organization?
Well, they can just find our website. We have a website, First Do No Harm SA. If you just Google that, you'll find the website and there's contact details, and there's links to lots of articles, position statements, resource material, etc. So, yeah, and we are very open to having these discussions. We've given talks in schools and to the general public, and in other settings. We've written articles in the general media. We've written 2 articles in the medical press because we feel like it's really important that our medical colleagues are also, in a sense, made aware. So yes, we are in the business of trying to advocate for more openness and more discussion that is rational and reasonable, collegial, respectful. But we are also understand and have realized that we will get this very negative response from time to time, and we just have to, in a way, continue to engage respectfully. I do know many members of an activist organization called PATH SA, which stands for Professional Association for Trans Health in South Africa. And I continue to try and remain on good relations and stay in contact, and to say, at the end of the day, we need to keep talking.
No, I think that's entirely right, and it's about, if nothing else, the freedom to speak and the freedom and the right to be heard, to be listened to, not to be agreed with or followed or anything as a sort of restricting as that, but just you have the right to speak and the right to be listened, and it's for the public to be exposed to all the views and make their own decisions. I think that's really important, because this is not an abstract sort of hypothetical issue. It's not about a faraway country. It's about people's lived experiences, and we know that more and more young people are somehow caught up in this thing that some people have called a contagion of, this gender questioning situation. So for many people, and when I have this conversation in different settings, people say, oh yes, my own child, my neighbor's child, my friends, my child's friend, my grandchild. I think many of us know somebody who's in this. And so the need for information, the need for openness, for dialogue, for debate, for hearing, for listening is absolutely urgent. And that there are different perspectives and they all need to be heard is really, really important. Absolutely. And we'll have to catch up with you again sometime to talk about your article on this issue and UCT, which, to punt my colleagues, has been published and can be found on dailyfriend.co.za. Janet Giddy, thank you very much for joining us.
Sarah, it was great to have this conversation. I appreciate the opportunity. Thank you. And goodbye to the listeners. And yeah, I hope this was helpful in some way.